start off with a couple of those things because they're common questions. Egg donor selection. If you work with an IVF clinic, whether it's us or someplace else, usually your egg donors, please come in, are already medically screened, psychologically screened. They may or may not be known or anonymous or what we call identity release. And they're available for use in a relatively short time period. If you get an agency donor, the agency donors often are either not psychologically screened, but they're basically hardly ever medically screened. And you want the medical screening to be done. You want your donor ruled out if they have to be ruled out. There are some things that come up that sometimes we'll talk to you about. Let's say you came through an agency. Turns out we medically screen your egg donor, and 1 in 30 people are cystic fibrosis carriers. So she's a cystic fibrosis carrier. So that may rule her out, but if you really like her, I might call you guys up and say, listen, 1 in 30 people are cystic fibrosis carriers. We can screen you, both of you, if both of you guys want to donate sperm, and if neither of you are cystic fibrosis carriers, we can still go forward with this donor. So those are some medical hurdles that can come up. The egg donor matching process often takes as long as you want it to take. And I say that with a little bit of tongue-in-cheek because there's a lot of very nice young women out there who actually want to be egg donors, believe it or not. They get compensated for it. They're just giving their eggs. They want to help people have families, and they are really, happy to do it. That's why they usually come back and donate several times. But getting the right fit for each individual couple is a challenge. Sometimes it depends on ethnic group. Some people are really focused on family history, like absolutely no family history of diabetes, because I have family history of diabetes. Some people are extremely focused on height. And when you match with an egg donor, there's going to be some things that are a little bit capricious that you're allowed. So for me, I wore glasses my whole life, and when we were looking at egg donors, I was like, I don't want an egg donor who's nearsighted. And that was silly, right? There's no reason to rule somebody out for that, but you're going to have those discussions. The egg donor matching process usually starts with a profile. In our practice, there's childhood photos, and then there's direct communication with the egg donor nurse coordinator or the coordinator that works the process. If you're working with an agency that has known donors, there's known exchanging, identify information, and then there's known that you're going to have a structured conversation, either virtual or in person. So there's different kinds of donors out there. I'm going to stop there for a minute because I may have generated questions just with that kind of opening into finding an egg donor before we talk about carriers. Yes, sir.
PGS, do you do 3-day or 5-day?
We do comprehensive chromosome screening, which is a proprietary testing technology that's only available at 9 clinics in the United States, and it's been validated by 5 prospective randomized trials at this point, and it's only day 5. Our entire practice is day 5 culture, day 5 transfer. In fact, approximately 40 to 50% of all of our patients are only transferring 1 embryo because of the success rates with not only just not even doing comprehensive chromosome screening, but with regular embryos. Does everybody know about embryo testing? I didn't get a chance because I had to talk so fast up there. So we all have basically 46 chromosomes. The vast majority of miscarriages have 47 or 45 chromosomes. Down syndrome children are very special, but they have 47 chromosomes. So ruling out chromosomal abnormalities up front can increase chances for success and perhaps reduce some stress on your side. It is true what Dr. Danishman said is that the vast majority of embryos from egg donors are chromosomally normal. So it's not necessary, but some intended parents, it's really important to them that they know that they're not going to be in a situation of are we going to have a termination for X, Y, or Z. So what happens is you grow an embryo to the day 5 stage, which is the blastocyst stage, and at that point in time, the blastocyst is actually trying to break out of its shell, so it's puffing up, And we make a little nick in the hole of the shell, and the placental cells actually prolapse out. And you take a laser, you put a little suction on it, you take a laser and you buzz off basically 5 to 10 cells. So you're basically getting a biopsy sample. Chances of harming the embryo are actually less than 1%, documented in a prospective randomized trial, which is the gold standard in medicine. That goes in a little tube, gets sent to another laboratory called RMA Genetics, and basically they amplify signals on each chromosome 30 to 40 times with high fidelity, and they give you a result that has an error rate of 2 per thousand. So we say it's 99.8% sensitive and specific. If your embryo is abnormal, it's abnormal. If your embryo is normal, it's normal. For baby number one or child number one, it's probably not as important, but what I find when I deal with intended parents that since the vast majority of you guys are going to be using a young egg donor, you're probably going to have extra frozen embryos. And when you have extra frozen embryos, and you're working on baby number two, I know you can't even think about that right now, you might want to know whether you want to have 2 boys or a boy and a girl. And that kind of makes it a little bit different, right? It's a different concept. The other thing is that every time your carrier comes through, that's costing you dollars and cents. So maximizing your chance for pregnancy is part of what this process is. So doing embryo testing can maximize your chance for pregnancy. So that was a complicated question, but thank you for doing that. Any other egg donor questions?
I'm sorry, can I ask one more follow-up?
Please.
Do you allow sex selection for even the first child?
We talk about it. As a practice, our practice policy is that we're going to have you sit down with our psychologist and understand there's so much responsibility in primary gender selection. Sometimes you don't get what you expect, and so I would leave that to Dr. Tuttle, our psychologist, and ultimately, usually the decision amongst the intended parents is that there are 2 equivalent embryos, then we want to transfer X gender, so we have a strong preference. Very rarely are we in a situation where somebody does not want to, so let's say you want to have a girl, absolutely positively you want to have a girl, but your best embryo is a boy. Then I would basically call you up and say, do you really want to have a lower chance for pregnancy with this? Because you never know what you're going to get. Sometimes we get the sheet back and we have 7 embryos, and even though it's supposed to be 50-50, we'll have basically 5 of one gender and 2 of the other gender, and the ones that people want invariably are not the best ones. So we play that game. So the blanket answer is we discourage primary gender selection. The American Society of Reproductive Medicine has a practice committee opinion on it, also saying we shouldn't do it as well. Some of this is also driven by what happens in Asia and Saudi Arabia, where they've managed the male-female relationship so dramatically, it's nearly 60-40 in some places. There's villages in India where there's 1 girl and there's 50 boys because they've been committing infanticide and things like that. And in Asia, same thing. In China, the same thing. So this is a global problem, and so that's the point of the ASRM position. Anything else? Okay, let's talk about gestational carriers. So it's interesting to have this woman in your life who's really probably going to be the nicest person you will ever meet. And then they have a husband who's willing to let her do this. And I have to tell you that our first gestational carrier, our second gestational carrier, I love them, I love their families, I know their kids. It's a really special relationship. And they are doing this amazing thing for you, so you can't help but love them, but they're really the nicest people that I meet in my practice. And no offense to my regular patients, but these are women who like being pregnant, they want to help people have families, and they are willing to go through this medical procedure, shots, this, that, the other thing, and have a baby, and go through getting their body back after having a baby to go through this. So they're really special people, and it's important that when you do your, so you're going to eventually meet your gestational carrier either by phone or by Skype and then in person. If you don't like them, that's a reason. If you're in your gut, just there's something that you don't like, even though it might take longer to find another gestational carrier, you probably shouldn't go through with it, because this is a very intimate relationship, probably the most intimate relationship beyond having a partner that anybody would ever have. And it's intricate, and there's places for speed bumps to come up in it. Really, your gestation, your agency, their job is to navigate this basically 12-month relationship, from matching to preparing to travel time, getting you guys get to know each other, embryo transfer, so that's the medical, right? So the gestational carrier gets screened medically, and then they come to my office for an embryo transfer. And then there's 9 more months of relationship, travel, visiting, cards, regular communication, contact. I mean, we've had carriers that felt like they wanted more from their intended parents. They want them to call more, they want to be in contact more. Definitely we've had carriers who have been like, would you please tell these people to leave me alone, right? I don't need him to know what I ate today, right? It runs the gamut, so you need to know. And so Dr. Sylvester kind of said the same thing. As an OBGYN, it's hard for me to take off my clinical hat and then to be a patient, so I've got to do both of those things now. There are definitely times that I bite my tongue when I hear what my gestational carrier did today or so on. I mean, in our first journey, our gestational carrier at 38 weeks went to the Outer Banks of North Carolina for her annual family reunion. It was like 100 degrees. And in my head, I'm like, oh, she's going to pass out. What did she do? She passed out. She had heat stroke. She went to the emergency room, and she's fine. Because pregnancy is a normal condition. And women make it through. There's 60 million human beings. We've been having babies for 60 million years. And women, healthy women having babies actually do it very well. And that's what a gestational carrier does. So it was a funny phone call because she called up and she says, I know you were worried about this, but you didn't say anything. But it worked out fine. A lot of the timeline questions come out, so it usually takes longer to find a gestational carrier than a egg donor. It is possible, some people break it up. They find an egg donor and make embryos first, and then they find a gestational carrier second. That's okay to do. For some couples, especially for single dads doing this, that's their bandwidth of what they can do. When you break it up like that, I think it might be a little bit harder because you got to just keep getting going twice, but it's more than reasonable to do. Any questions? Yes, sir.
Question. You talked about interviewing outside gestational carrier. Do you recommend interviewing or talking to the gestational carrier's family? Because we've heard all the carriers and how important it was with a husband or a partner.
When you meet your gestational carrier, you're going to meet them with their husband. And some agencies actually recommend you go to where they live and meet them there and pick them up at their house. The gestational carriers often have background checks. They might have had a social worker visit their house, but if you know somebody's going to come visit your house, well, you're going to make sure you're on best behavior. But just to see where they live, what's going on, and so on. So yeah, you're going to have a relationship with their husband and their children. The relationships with their children are actually very interesting because I don't know, there's been a sea change in the way kids view LGBT families, and the kids are fine with it. They think it's great. It actually was funny what I think it was the second carrier that said the 2 boys that are the sons of our gestational carrier right now, they're like so excited to give this baby to Mark and Greg. So they got it, and they're 3 and 6. So it's just crazy. So yes, you're gonna have a relationship with their parents. The parents and the children. You're not gonna meet their children right off, but as you progress through the relationship, you're gonna get to know them all, and probably sooner rather than later. The other thing that I always ask the gestational carriers is how does the rest of your family feel about this? Because that can be important. And some of the gestational carriers say, well, my husband supports me, and I don't mind what anybody else says. But in general, the answer is, well, my mom knows what I'm doing, and she thinks it's such a special thing that they're supportive of it. Anything else question-wise?
What kind of split is there between anonymous and known egg donors?
Yeah, that's a great question. So all across the country, all across the world, and this has been changing for the past 20 years. There's been this discussion about what's best for the parents who want to have the baby. But now it's actually shifted a little bit more to what's best for the unborn child, and then the child-to-be, who's then a 12-year-old, a teenager, a young adult. So there's all different kinds of anonymity, and there's not a right answer yet. So 20 years ago, pretty much everything was anonymous. An egg donor came in, she said, we're going to keep your name private, we're not going to reveal it to anyone, and this is what it is. You donate your eggs, you get your reimbursement. Legally, in the eyes of the court, you have no rights because you're donating eggs. Eggs have no reproductive potential to combine with sperm. You're not paying for that. Then they have to be put into a uterus that wants them, so you're not paying for that, so you're done. The only time this has come up is with known donation cycles. So known egg donor cycles have gotten into messy relationships in lesbian couples because somebody's the egg donor and someone's the gestational carrier. You guys don't have that problem. So there's completely anonymous. And now we have anonymous donors, but I tell all of them I can't guarantee their anonymity because with the advent of DNA technology, it's quite possible we're all going to have DNA signatures out there, and somebody's going to be able to find you in 20 years, right? Because you're going to be able to comb down, and they're going to have your profile, and they're going to be able to figure out where you went to school and what your sports you played and so on. You can find somebody on the internet pretty quickly, right? Even without DNA signatures. So we started asking our donors about 2 years ago, would you be willing to be what we call an open door donor, which means, are you willing to be available to this child for medical reasons? Are you willing to be available to this child if they want to get in touch with you? Hi, Vicky. Do you guys know Vicky Farrar?
Oh, thanks.
She's with Worldwide Surrogacy. She's my friend. She works in Fairfield.
Hi, Mark. It's so good to see you.
So then there's this, so we started asking these young women, these 25-year-old women, and they all said yes. They said, you know what, if I was a 25-year-old child and I didn't know how to prove the rest of my family history, I'm fine with that. They're very clear that they're just donating their eggs, but their privacy line is a lot different than, let's say, privacy lines 20 years ago, because they're all on Facebook and Instagram posting everything anyway. So that being said, when we ask the question about are they willing to be open door donors, the answer is yes. So then what happens is that their private information is held by an attorney, and the attorney's responsibility is over basically every 6 to 12 months they're supposed to confirm, get in touch with them where they are, and then basically when you talk to your child, 4 to 5, they're going to say, where do babies come from? You're going to introduce the concept that they had a gestational carrier, whatever word you're going to use with. So some people use the word tummy mommy. I try to avoid the term mommy because mommy's a parenting phrase. So, but a very special woman who carried you in her belly, who helped us have you. So that being said, they're going to want to know where babies come from. Then by the age of 10, they're going to know, hey, I need to know more. So then that's when you say, we've got this donor profile, we worked hard to pick up this donor, Daddy and Papa did this, and here's you as an embryo, and we love you so much, and so on, and they'll go forward with that. And then by 12 to 16, 12 to 18, they might want to know if they have half siblings, they might want to know more family history. They might want to actually just get to know that this person is a real person. And in fact, I don't know if anybody's a mental health professional in this room, but the interesting thing for kids is they do want to know that this person was a real person. And they just need to sometimes just connect with that. So open door donors are willing to do that. Then there's completely known donors, which known comes in 2 varieties. Exchange of private personal information, and then you are responsible for keeping in touch with them on a regular basis. And then there's you just meet, but there's no exchange. And to be honest with you, between those two, if you're going to meet, you might as well exchange personal information. I don't know why this other option exists, but I think it's so you can call a donor known. The other thing, when you pick a donor, you have to look past what they look like, right? Because you're accessing their family tree, their family genetics. So it's not only their personal medical history, but their brothers, their sisters, their aunts, their uncles, their brothers, sisters, aunts, uncles, family history, maybe heights, maybe weights, maybe what they do. A lot of donors might not come from the same opportunity to achieve like PhDs and so on, but they can still be smart, they can still do different things. So also be careful if you're picking an egg donor based on their academic achievement. Really look at the rest of their family, because sometimes that person might be an anomaly, or sometimes that person might not be as advertised. So does that answer your question about?
Yeah.
I know Ron owes you 2 minutes.